I'm Mohamed, President of the United European Gastroenterology Federation. This is an organization that represents gastroenterology in Europe through a series of societies that have formed the federation. These societies include groups that focus on special aspects of gastroenterology, but also the national societies of gastroenterology of each of the component countries of the European Union, as well as others from the Mediterranean and parts that are adjacent to Europe. So in total, we may represent something like 50,000 gastroenterologists, and we put up a meeting called the United European Gastroenterology Week that is currently occurring in Vienna. This is the city where UEGF has its headquarters, but not always is host to the Congress. The Congress is an annual Congress and moves around Europe in cities that can provide the facilities for such a big gathering. At the moment, we have over 12,000 professionals here in Vienna attending this Congress. The mission of UEGF is to promote gastroenterology and to facilitate gastroenterologists interact with each other, become aware of the novelties, get continuing medical education, and we also serve as a scientific forum where researchers, both clinic and basic, discuss their findings, get peer review, and in essence advance our specialty and medicine in general. So it's a very important role. We also are in constant contact and communication with the Health Commissioner office in Brussels, because we feel that prevention of gastrointestinal disease is one of the major functions that such a large organization should have. And in particular, we are concerned about preventable serious diseases like colon cancer and other GI malignancies, hepatitis, nutritional problems, obesity, etc. Many medical problems that affect the population of Europe that we feel that we can assist, but that requires the coordination with the European authorities in order to do so effectively. In this Congress, a number of important novelties are being presented. We have novelties in diagnostics, new technologies that help advance the capabilities of endoscopy and surgery through one of its member organizations, the SMGE, which is essentially an organization of national societies, not only European, but also including those in Northern Africa. We feel that we represent also the countries that are located around the Mediterranean, and in fact their participation in this Congress is very, very important, very substantial. We have many representatives attending and also participating in the various clinical and scientific activities.
Second press conference of the meeting. I'm very again appreciated your attendance, and to re-emphasize the importance of delivering our message to the lay public, which is our aim, to publicize what we do at a political and a lay level. Today we have a special day in that we're covering three topics again, and we're starting with a very important topic of inflammatory bowel disease. I not only have to acknowledge the help of our Public Affairs Committee, the experts are here, but also further experts of a very important group to us, the European Crohn's and Colitis Organization. In addition, I'd also like to acknowledge the presence of the European Federation of Colitis Association, and here you see they were the net beneficiaries of the pain I had to suffer during the fun run, where we gave 4,000 euros to a very worthy cause. And just to know that this organization is pan-European, and we wish them every success in their activities. Following on from there, of course, we have here with us, of course, Jean-Frédéric Ecolombel and Professor Walter Rhenish, local expert, and we also have experts here from the main organization who would be available after the press conference to help you with any questions you might have on inflammatory bowel disease.
My name is Walter Rhenish. I'm from the medical department of internal medicine in Vienna, and I particularly like to thank you for your interest in this today's press conference, which addresses here inflammatory bowel disease and the burden of inflammatory bowel disease. First of all, you should know that inflammatory bowel disease are chronic diseases of an organic origin, and these diseases progress to bowel destruction. So this makes it different to what you have heard maybe the previous days on irritable bowel syndrome, with which inflammatory bowel diseases are often mixed up. So patients are actually afflicted by symptoms like diarrhea, up to 10, sometimes up to 10, 15 bloody stools, abdominal cramping, abdominal pain, and the general well-being is often quite poor. So patients are afflicted by symptoms which limit the activity of those patients, or the physical activity of those patients, so that these patients are sometimes remain in a close proximity to a toilet. These symptoms, but are also quite embarrassing for the patients, and therefore these symptoms are very likely to be tabooized. So this means that patients with inflammatory bowel diseases are at risk to withdraw from social activities and to suffer from anxiety disorders and depression. There are numbers that up to 30 to 40% of patients have to lose their job as a result of the disease, and up to 60 to 70% of the patients report that they are influenced in their daily work. So the quality of life of these patients is quite poor. But it's not only the quality of life which is of concern in IBD. The disease is a progressive disease, and after 15 years after diagnosis, for example, for Crohn's disease, up to 70% of patients have to underwent at least one intestinal resection. And this is not a cure for the patients, because the disease after resection comes up again in a high percentage of patients, so that sometimes, and not only sometimes, even quite often, secondary and third resections are necessary. And the patients are also at an increased risk to suffer from colorectal carcinoma. But despite the importance of these diseases, particularly from health politicians, are considered as orphan diseases, and this is not the case. So here you can see numbers, the numbers of patients, of inpatients treated in Austria within the last 15 years, and you can see this steep increase of inpatients of 270%, and this is quite unique among diagnoses in internal medicine. But despite these high numbers and the numbers of patients with IBD treated in Austria inpatiently in 2007 was around 20,000 patients. And so we extrapolate that the incidence or the prevalence of the disease is about 0.8 up to maybe 1% of the patient population. So it comes quite close to a patient, to the prevalence of rheumatoid arthritis. But if you ask the people on the streets how aware they are on Crohn's disease or ulcerative colitis, the results are quite intriguing, because knowledge is very low. Only 6.7% in the public know that Crohn's disease is a disease of the intestine. Only 3.8% know that ulcerative colitis is a disease of the intestine. And so this leads to this lack of awareness, I think, is also a reason for the fact why it takes so much time that patients from the first symptoms can expect a final diagnosis of IBD. And the median delay here is 3.1 years. But actually, what does this mean for a disease which is progressive like Crohn's disease? This means that about an addition of 30% more complications is not treated, or could be maybe avoided early on. But now I'd like to pass over to Jean-Frédéric Colombel mentioning.
So if you walk around all the sessions during this meeting, if you see the name IBD, the session, you can be sure that the session will be packed. All the sessions about IBD are packed. Why is that? I think there are fundamentally three different reasons. The first one is linked to the epidemiology of the disease, and I will say a few words about that. The second one is that because we are making very important progresses regarding the cause and the pathophysiology of the disease. And the third one is that because a treatment of this disease is changing. So first, about epidemiology. We have in the room one of the best experts in the world of IBD epidemiology, Professor Pierre Munkholm, who could comment on that further later. But what you should know, as Walter already alluded to, it's not IBD, Crohn's disease, and ulcerative colitis are not rare disease. We can estimate that approximately 1.5 million people are sick with IBD in Europe and approximately the same number in the US. Very interestingly, the epidemiology of the disease is changing. Traditionally, these diseases have occurred in Western countries. For instance, first in England, in Denmark, Sweden, France, Germany. But we have now a very interesting observation. Some countries where IBD were almost absent in the past, some of the countries are now affected. And this is, for instance, the case for Eastern European countries, where the incidence of IBD, ulcerative colitis, and Crohn's disease is rising, and also, for instance, Asian countries. For instance, Japan was not concerned at all with Crohn's disease a few years ago, and now this is a huge problem also in this country. The second very important point is that these diseases are diseases of the young. That means that when you will deal with a patient with Crohn's disease or ulcerative colitis, basically you will have this patient in your practice for your whole life. And actually very often she or he will survive you. So the second point is about the pathophysiology. These are very complex diseases. It's like all chronic inflammatory disease. You have the genes and the environment. And the resultant of that is a disorder of the immune intestinal systems. So if you are to get Crohn's disease, this is because you have a genetic susceptibility. And we have made tremendous progresses regarding the identification of genes. So there is not one gene that causes Crohn's disease or UC. In 2001, we identified the first gene, which is called NOD2, NOD2, which was the first susceptibility gene for Crohn's disease. But since we have identified 30 different genes, or I should say loci, meaning some different points within the chromosome where there are some susceptibility genes. So it's a very complex genetic disorders. But nothing can happen if, on this genetic background, you are not encountering the environmental factors. And this is where we need to make progresses. We have not made any progress regarding the environment within the last 10 years. What we know is just smoking. Smoking is a risk factor for Crohn's disease and, surprisingly, is a protective factor for UC, which is an amazing observation never explained. Besides smoking, a lot of hypotheses. Tons of hypotheses. Food, hygiene, pollution, and so on, but nothing is proven. And this is where I think we should make a lot of progresses. And I guess that within Europe, we are in a very good position because we could compare countries with a high prevalence of Crohn's disease, for instance, Denmark, Sweden, with countries where the Crohn's disease is just rising. And this is a perfect place to find new environmental factors. Finally, what about treatment? This is where most important changes have occurred in the last years. So the traditional treatment for IBD were the 5-amino salicylates, then steroids, then what we call the classical immunomodulators, azathioprine, methotrexate. But the revolution has come, which are biologics. And mainly, and these are the only biologics available in Europe, the antibodies against TNF-alpha. With the use of these new treatments, we have now changed our goals. So we are not just talking about clinical remission. Now we want to change the gut. We want to heal the mucosa, and eventually we want to reverse the disease. And this is our ultimate goal. Our goal is cure, which will be no treatment and no disease. I think it will be achievable, maybe not in the next few years, but certainly in the future. And of course, it's all about strategies now. We have new tools, very powerful tools, but we need to learn how to use those new tools in order to have the best benefit for the patient and also to avoid the risks that may be linked to these new treatments. Thank you.
My hospital is a busy general hospital caring for the local population as well as taking referrals of a more complex nature from throughout the UK. I think it's true to say that endoscopy now dominates the diagnostic workup and management of patients with gastrointestinal conditions. Endoscopy gives us a wonderful insight into what's going on. It looks in colour, it looks real time, and gives us direct access for biopsy of tissue. To give you an idea about numbers, my hospital 10 years ago would be doing 3,000 endoscopies per year. Now we do between 12 and 15,000 procedures per year. So throughout the world there's been a rapid increase in the volume of endoscopy, particularly with the advent of bowel cancer screening, which the colonoscopy is the primary modality. Now, traditionally, biopsy of tissue has been our mainstay for making the diagnosis at endoscopy and has been pivotal in the subsequent management of patients. But there is a major change going on at this point in time, and for many indications, I now think that endoscopic biopsies are probably no longer required, and this is a major shift in the way we look at and manage patients. So 2008 heralds a new era in which optical biopsy, the ability to make a diagnosis at the time of the endoscopy, is becoming a practical reality. And one of the techniques which I'm going to describe, my colleague Professor Neurath was going to describe another one. He's currently not here, but may well be coming along later, really brings this into the practical sphere where we can use this in day-to-day practice. An optical biopsy has many advantages for clinicians, for patients, and for healthcare providers. For one thing, because we can make a diagnosis at the time of the endoscopy, it reduces the number of procedures which are needed. There's no delay in terms of treatment because we can make an instant decision. If the diagnosis is one which favours an endoscopic management, we can go ahead and apply that endoscopic treatment. If it's one which requires surgical intervention, the patient can immediately go on and have surgery without delay. So inherently there's less patient risk. Sometimes we will look and see something which doesn't require biopsy or removal, and therefore there is less intervention potentially being done without relying on histology. And the really good news is that you can tell the patient at the time of the endoscopy what the diagnosis is, what their long-term cancer risk potentially is, and make arrangements, avoiding the need to bring them back to outpatients, a one-stop shop, so to speak. So within this system there are massive cost reductions, particularly in reducing histopathology. Histopathologists spend about 60% of their time looking at small biopsies or small polyps, and I believe that many of these now can be adequately diagnosed in vivo at the time. Narrowband imaging is the technique that I'm going to specifically talk about. It has many advantages at endoscopy. It's simple. We just push a button and we can see using narrowband imaging. It's low cost because it's built into the endoscope, so it involves no additional cost after the endoscope has been bought. It does appear to be accurate, and I'll mention a bit more detail about that, and it's easily incorporated into day-to-day practice. Many of the other techniques for optical biopsy are technically quite difficult, and there is a significant learning curve. With narrowband imaging, I think the learning curve is considerably less and quicker. This is how it works. Basically, standard white light penetrates relatively deep into the mucosal surface, but by narrowing the bandwidth of the light, particularly into the blue spectrum, it picks out preferentially the mucosal surface, and in particular capillaries and blood vessels. So we get enhanced contrast for superficial capillaries. The picture on the left is a white light picture of the normal bowel surface. The picture on the right is with narrowband imaging. And just to give you some quick examples, this is normal lining. The magnified view on the right, you see the shimmering effect. That's blood passing through tiny capillaries real time. This is the sort of detail with magnification that we can see. And the second video shows the detection of a flat precancerous polyp in the colon, in the right side of the colon. And again, with magnification, we can see not only the structure of the surface crypt pattern, but also the capillaries around that area, which show thickened, much darker capillaries, which show that this is a precancerous lesion and needs to be removed endoscopically. So with a combination of narrowband imaging and with magnification, pit pattern and vascular pattern assessments of lesions can be made real time. And to give you some further examples, here we see a hyperplastic polyp, which is a benign lesion, one that can probably be left in situ, compared to some precancerous lesions, adenomas. And the thing that strikes you about the adenoma is we have a darker brown pattern to the capillary structure, as well as being able to see aberrant crypts in addition. And then finally we have a cancer where we have very abnormal vasculature and complete disruption of the crypts in the center. So with a relatively quick push a button, look in more detail at the surface, we can start to make a true optical diagnosis. The early data suggests good sensitivity and specificity when using narrowband imaging with magnification. And the thing that has really come home to those who've used this is that by simply looking at a colour change, what's called vascular pattern intensity, this browner appearance, we can make a diagnosis. And this makes it much simpler for endoscopists to make an immediate decision, rather than having to wait for a period of time with dyes and make a quite difficult to call interpretation on the pit pattern, which has been the traditional way of making an optical biopsy. So this is a very simple and quick way of doing this with high levels of accuracy, probably as good as histopathology. So endoscopy using optical biopsy, I think in the future we're going to be detecting, assessing, using techniques